All right, hi everyone. So you'll see, I just realized now that the banner hasn't changed since the last time I gave this talk. I gave this talk at a SASP training workshop in November last year, and thought it might be interesting and of relevance to this group. So I've offered to give it again and modified it slightly since November. Apologies in advance if it's a little bit too kind of basic. I mean, it was aimed at physicians who were, aiming to start stewardship programs in their hospitals from Southern African countries, but hopefully it will be useful to some people, especially registrars. And there is going to be a little interactive components towards the end. So before speaking about antifungal stewardship, it's probably important to think about, or just to kind of go over what we actually are discussing. And really, especially in our setting, but generally, this really relates to invasive candidiasis mainly, because invasive mold infections are much less common and really in very specific areas that they're dealt with. I will touch on them a little bit, but we're really speaking about invasive candidiasis. And I thought it was important to define that spectrum and clinical syndrome of illness. And it comprises of two kind of connected conditions. One is candidemia, so yeasts of Candida found in the bloodstream, and deep-seated candidiasis, which obviously are related to each other. And there's really only three entry points for invasive candidiasis. One, and that is, breakdown of mucocutaneous barriers. And one is in the so people you can imagine who have intestinal surgery and or have mucositis are at risk. The other is through skin breakdown, and the risk factor for that is intravascular catheterization. And then much less commonly, but the third kind of portal of entry is via the bladder. Sorry, just 1 second. I need to open the door here. This is one of the hazards of working at home. 1 second, sorry. Okay. Thank you, sorry. And so Candida then enters the bloodstream and then can disseminate to other organs. And you can see on this little Venn diagram here, the kind of relative distribution of deep-seated candidiasis. So just organ involvement without bloodstream involvement and pure candidemia. And it's divided into about a third. So a third of patients will have overlap with deep-seated, at least clinically or radiologically evidenced deep-seated candidiasis and candidemia. And a third will just have candidemia on their own. And the sensitivity of blood cultures, so the sensitivity is about 75%. I don't know what that's based on, but that's what the kind of literature consistently reports. And so if there is bloodstream infection, it will be positive in 75%. And so the overall yield, because 2/3 have candidemia of blood cultures in invasive candidiasis, is about 75%. And I think that's important just to bear in mind as we go through the talk. So why is antifungal stewardship needed, and specifically antifungal stewardship relating to invasive candidiasis? Well, candidiasis is an increasingly important nosocomial infection. In the Northern Hemisphere, it accounts for consistently one of the top five pathogens isolated on blood cultures. You can see that here from a survey in the US. So it's, one of the top five organisms isolated on blood culture and in hospital, but relatively it actually accounts for quite a high mortality. The attributable mortality is a little bit difficult to ascertain. Often these patients are very sick, but it's associated with high mortality. And worryingly, non-albicans species are increasing in prevalence over time, both in bloodstream infections and associated with deep-seated candidiasis. And you can see that over here. Candida species, albican species is fairly stable over time. This is a recent survey, a large survey across the US. But in the middle here in these dashed lines, non-albicans species are increasing. And now overall in the US, albicans accounts for only about half of isolates in surveys. Glabrata is the second most commonly isolated Candida, and that obviously has treatment implications. What about in South Africa? And it's possible, and in Africa more kind of generally, it's possible that there's been an epidemiological shift. Disease with Candida, so candidiasis that's non-invasive, has been driven, I think, in Africa by HIV, which, as we all know, manifests as mucocutaneous candidiasis, not really invasive candidiasis. And just there aren't a lot of publications on this across Africa. It's very scarce, and in South Africa, very few as well. But looking back at an early Soweto study, which was done from 1998 to 2007, the incidence of candidemia, actually, this is I said invasive candidiasis, but candidemia was very low compared to Northern Hemisphere countries. But as time went on, the proportion of people that were diagnosed with invasive candidiasis were HIV positive. And in a much more recent national survey, so across a couple of hundred hospitals done by the NICD, the incidence of candidemia was very similar to what is seen in US hospitals. And so maybe this is reflecting a shift in healthcare practice, at least in South Africa, but potentially across Africa, with more access to antifungal therapy, more access to organ transplantation, immunosuppression, surgery, all risk factors that can predispose to invasive candidiasis. In public sector facilities in the South African survey, albicans was still the predominant species, close to 50%, but there's a different distribution in private sector hospitals, where most episodes were caused by non-albican species, mainly parapsilosis, interestingly, and of great concern is that only 37% of those parapsilosis species were susceptible to both fluconazole and voriconazole. And even more concerning is the emergence of Candida auris and its detection widely across South Africa. So just to remind people, Candida auris emerged almost simultaneously across multiple continents in around 2009. And it seems like there was, genomic evidence suggests that there was kind of independent simultaneous emergence with then clonal expansion in each area and ongoing selective resistance pressure. So different clones emerged, but almost simultaneously. Maybe the kind of late notice of this was also because of misidentification in conventional lab systems. But it is established in South Africa. It's becoming much more important in South Africa. Mark actually spoke last week about why it's so important as a nosocomial organism, which I'm not going to speak about again. But in the latest survey, about 15% of candidemia episodes were due to Candida auris, and it's now the third most common across South Africa after albicans and parapsilosis. The main problem with auris is that it's got basically intrinsic resistance to fluconazole through the ERG11 gene mutations, and it's got variable susceptibility to other azoles. So most isolates, almost all isolates, are multi-drug resistance, and even echinocandin resistance through FKS1 mutations have been described. And again, attributable mortality is difficult, but it is associated with very high mortality, close to 50% in South Africa. And so this is a clear worry and concern. And there is just general global emergence of antifungal resistance to all existing classes of antifungals. And you can see here on the left, this really nice review in Science, which I think I really recommend people reading, that in both plants on the left in blue and white and humans on the right in red, there is increasing resistance to all classes of antifungals across the world. And I just want to read you, I've written this down quickly, a phrase from that paper, and this is what the authors say: to avoid a global collapse in our ability to control fungal infections and to avoid critical failures in medicine and food security, we must improve our stewardship of extant chemicals. We also know that on a patient level, fluconazole exposure is associated with candidemia that's caused by non-albican species. And this has been demonstrated in non-neutropenic ICU patients and in stem cell transplantation with the detection of Candida krusei after fluconazole exposure for prophylaxis. And at least in neutropenic patients, you can see on the right in this one study, MDR Candida species isolated on blood is associated with excess mortality. So having MDR Candida in the dashed lines versus not in the solid line. So this is really a global problem and impacts on care and treatment decisions for our patients. So before I get into the 6 or 7 principles of stewardship that I think are important to guide practice, I just wanted to run through the available antifungal agents and where they're best used. because obviously this is a key component of antifungal stewardship. So really there are three classes that we use in clinical practice, not in plants. So the azoles, everyone will be familiar with fluconazole. These work by inhibiting cell wall synthesis via inhibition of this enzyme, which inhibits ergosterol synthesis, and they are fungistatic, except voriconazole is actually fungicidal for Aspergillus. They generally have more yeast cover, except voriconazole and posaconazole are pretty good against molds, which I'll speak about just now, itraconazole against dimorphic fungi. So the spectrum of activity for fluconazole is really against Candida species and sensitive Candida species, almost exclusively albicans, and most Parapsilosis are also still sensitive. And this is really only indicated for mucocutaneous candidiasis and directed therapy against invasive candidiasis. So albican species or susceptible other species that have been identified. And then we use it extensively, and it is used extensively for prophylaxis against invasive fungal infection in stem cell transplantation and other high-risk hematological patients. And really that's used in units where the prevalence of invasive mold infection is low, around less than 6%. Voriconazole also has excellent activity against yeasts, but it has an important role against Aspergillus, where it's, as I said, fungicidal, and actually a broad range of molds, but importantly not mucormycosis. So if that's suspected clinically, then voriconazole shouldn't be used. It is used primarily, at least in our practice and probably globally, to treat invasive aspergillosis and as directed therapy against invasive candidiasis for susceptible organisms that are non-albicans. And then we use it, it's used less internationally for this, but we use it for certain high-risk patients as a prophylaxis for invasive fungal infection. So who we think are at high risk of having mold infection, aspergillus, or who've previously had mold infection that we use for prophylaxis. Itraconazole is reserved basically for treatment of dimorphic fungal infection. We don't use it to treat yeasts. It's got no benefits over fluconazole in terms of the spectrum of activity, and it's much less well tolerated. Posaconazole is only registered for prophylaxis, not for treatment. It's got excellent broad cover against molds and yeasts. And it is the preferred agent for prophylaxis in high-risk patients because of the favorable PK and tolerability. But we don't have access, at least to the form that we would want, which is the capsule form that has reliable PK. Polyenes, amphotericin B, inhibit cell wall synthesis by binding ergosterol. They have broad spectrum of activity against almost all fungi, and it is a first-line therapy for almost all infections, although limited by toxicity. And echinocandins also inhibit cell wall synthesis, this time by binding to beta-D-glucan. And they have excellent activity against Candida species, with some in vitro activity against Aspergillus, and in some cases could even be considered for prophylaxis in high-risk patients who can't tolerate voriconazole, for example, but really for treatments of invasive Candida infections. And they now recommend, and I'll speak about this a little bit later, as first-line empiric therapy for high-risk patients with neutropenia, and for those with suspected invasive candidiasis. And then, of course, for directed therapy against fluconazole-resistant strains like Candida auris or glabrata. So I'm going to now go into my six or seven principles of antibiotic stewardship, and you can use these to guide your practice. So the first principle is to start early treatment if invasive candidiasis is either suspected or proven, and there's a couple of studies to support this. Both of them retrospective cohort studies. The one on the left involved 230 patients, and this was timing of start of fluconazole for any candidemia, and you can see that the longer you go out from the day of culture, the higher the mortality. And this was replicated in a cohort of patients who had septic shock and then were identified as having candidemia on blood culture. And there was a survival benefit if they were started on an antifungal agent, an anti-candida agent within 24 hours after after the blood culture was taken. And that was really a massively increased odds of dying if antifungal therapy was delayed in these high-risk patients. The second principle, which people I'm sure are all aware of, is the importance of source control. And this differs slightly for neutropenic versus non-neutropenic patients. So the guidance is in non-neutropenic patients to always remove lines. How do you know that the line is implicated in invasive candidiasis? Well, it's very difficult. What guidelines recommend is that there's a 5-fold increase in the CFU count compared to the blood culture drawn peripherally. And this is important in neutropenic patients, where taking out the line is often very risky and difficult because they have difficult venous access. They need central venous access for their chemotherapy and other treatments. And also they are at much higher risk of getting candidiasis from mucositis. And so in patients with mucositis who don't convincingly have line infection, it might actually be prudent to leave it in. US guidelines say that that's okay. European guidelines recommend removing lines even in neutropenic patients. And the reason for this is because it's really been clearly demonstrated that removing central lines in invasive candidiasis is beneficial in terms of survival. This was a meta-analysis of 7 randomized controlled trials, and you can see even across disease severity on the bottom, measured by Apache score quartiles, the mortality was reduced when the line was removed in the solid line versus retained in the dotted line, and that was across all disease severity quartiles. Wasn't significant at the most severe in the most severe cases. Maybe that was because of reduced power, but across all the others it was. Use of monotherapy is encouraged and in fact should be done. The evidence for this isn't very strong. It kind of makes intuitive sense, but there is, you can ignore the study on the right, which I included here in error actually after I reviewed it. I'll tell you about it in a second, but there's at least one randomized controlled trial showing that there's no benefit in dual therapy. This was a study of non-neutropenic patients with candidemia, and they randomized them to fluconazole versus amphotericin B plus fluconazole. There was a small signal towards improved treatment success with the combination therapy, 69% versus 57%, but no impact on mortality. You can see here the lines do deviate for treatment success, but again, no impact on mortality, and this wasn't even significant for treatment success. On the right, this was actually sequential therapy of voriconazole versus sequential amphotericin versus fluconazole, so it's not really relevant here, but in case you're interested, there was no difference either. So what treatment do you start off with for empiric therapy? So when I say empiric therapy in this context, I mean when there is a yeast identified on blood culture, but no, not speciated yet. And I guess also more generally for empiric therapy when you don't have a yeast on blood culture, which I'll talk about just now. But the guidance is to start with an echinocandin, and in certain cases, I'll speak about this in a second, fluconazole. And this is based on multiple randomized controlled trials. So the aggregate data meta-analysis shows that there's really no difference between using an echinocandin versus amphotericin B on outcomes, and specifically mortality. And the reason why it's recommended is because echinocandins are just much better tolerated. The problem is that none of these trials were designed as superiority trials. They were all non-inferiority trials. So it's going to be very difficult to show in the aggregate data meta-analysis superiority. But an individual patient data meta-analysis has been done. And in that, echinocandins were associated clearly with lower mortality compared to use of amphotericin B. So about a 35% reduction in mortality. For certain patients who are stable, who are not neutropenic, so that they haven't been on fluconazole prophylaxis and are unlikely to have a fluconazole resistant organism, you can consider fluconazole as an empiric therapy because it performs very well. But in most cases, it will be an echinocandin. So what about de-escalation? Just like antibiotic stewardship, we should always aim for directed therapy and de-escalate if possible. Guidelines have, at least US guidelines, have established some criteria for de-escalation. They're not really evidence-based, just on expert opinion. And they suggest that it's very important for the patient to be clinically stable after receiving about 5 to 7 days on echinocandin. They must have a susceptible isolate, and they must have negative repeat blood cultures. In my practice and my view, I think for Candida albicans, whether patients are clinically stable or not is less relevant, or in fact, if they have a negative repeat blood culture is less relevant, and because fluconazole is just so effective against Candida albicans and is, very favorable PK, that I think it's probably okay to de-escalate to fluconazole for albicans. But for non-albicans, I would definitely stick with this guidance. And I've just summarized in this table here guidance for specific organisms. So as I said, for Candida albicans, de-escalate to fluconazole. And because it's very well absorbed, you can transition to oral if the patient is absorbing adequately and so not in shock, and other factors for poor absorption. Candida auris, it is preferred to continue with an echinocandin, but treatment failure has been described, and so you may need amphotericin. Glabrata is very difficult, and I'm very interested in microbiology's comments later on. Guidelines suggest that echinocandins are preferred, but for susceptible organisms, you can consider fluconazole or voriconazole. Voriconazole is pretty good for Candida krusei. And I think if susceptibility is confirmed, then that is a good step-down option, although guidelines still recommend echinocandins. Parapsilosis, most are still susceptible to fluconazole, and step-down therapy is probably okay. But given Nalesh's data from the NICD survey, I think it's probably still worthwhile confirming susceptibility. Duration of therapy, this is the second last principle. I think we all know this, but just to re-emphasize that it's recommended a minimum of 2 weeks after the first negative blood culture with the following conditions, right? So no obvious metastatic complications, and that's part of the reason why it's important to look in eyes for endophthalmitis, which is an infrequent but important complication of candidemia and requires longer treatment, but all other metastatic complications. Patients must have clinical resolution of symptoms and signs that are attributable to the candidemia. In neutropenic patients, the neutropenia must have resolved, otherwise they must go back onto prophylaxis. And in order to define the duration of therapy, you'll have to do regular blood cultures. In our setting, we do it about 3 times a week. For patients that start empiric therapy, which I'm going to describe in the next slide, it can be difficult to know when to stop. But the way that I think about it, and I think guidelines agree with this, if patients are started on empiric therapy for suspected invasive candidiasis, but not confirmed, it's probably okay to stop if there's no clinical response. So to the intervention, right? So even if the fever continues, on broad spectrum antibiotics, you start an echinocandin and the fever persists, cultures for yeasts are negative. And I think this is a good situation to do beta-D-glucans, and if they're negative, in addition to the other factors, then it's probably okay to stop empiric therapy. Sometimes I also do abdominal imaging, but I find that the yield for that is very poor. So what about empiric therapy? And I'm speaking about genuine empiric therapy, so no yeasts identified on blood culture. And I think it makes sense to consider non-neutropenic and neutropenic patients differently. And just to say that in ICU patients, candidemia is not very common at all. So generally in less than 5% of ICU patients. And so really there have to be very strong risk factors in sick patients in order to start empiric therapy. Risk scores have been developed, they don't actually perform that well. But it should be considered generally in critically ill patients with persistent fever, plus risk factors for invasive candidiasis. And those risk factors include colonization, surrogate markers like beta-D-glucan, and I'll speak about the performance characteristics later. Patients who have abdominal surgery, necrotizing pancreatitis is also a risk factor. And then, all other disturbances of mucocutaneous barriers. For neutropenic patients, it's even more difficult because most patients are on prophylaxis already. And so I think about this in patients who have persistent fever plus a clinical deterioration on broad spectrum antibiotics. In patients without an obvious site of infection, I upscale fluconazole to echinocandin. And if there's any suspicion of invasive mold infection, specifically abnormalities on the chest X-ray or CT scan, or other features of potential mold infection like mucor, then I go with voriconazole or amphotericin B. I just want to emphasize that in both these scenarios, survival benefits of empiric therapy hasn't been demonstrated. And so really these patients must be carefully selected. So that wraps up the formal presentation. I've got 3 cases that we can discuss. I just want to open up the participant list and see who we can call on. Oh yeah, obviously it's going to be Tari. But Tari, I think I've already discussed these ones with you, so that's a problem. Is it Tamron? Tamron, aren't you a registrar at Tygerberg? Are you with us? Probably not.
She's a viro reg here.
Oh, so apologies, Tamron. Then I'm going to give this to you anyway. So based on what I've just said and what you know, this is the first case. A 64-year-old woman, known with diabetes, is admitted because of a stroke. She has a urethral catheter in situ. She's got poor glycemic control in the ward, and you're not called. You actually call us out because you're doing your microbiology time, and you call it out because yeasts have been identified in the urine. What will you do, or what will you advise? Tamron, come on. Okay, I apologize. Let's choose someone else. God, it's going to have to be Tari.
Okay, thanks, Sean. So essentially, we've got to address the risk factors of the patient, and one of them is that she's diabetic, and she's got a urinary catheter in situ. So let's start off with the diabetes. Obviously, control that. Try and get the glycemic control as good as possible. Insulin therapy, etc., etc. And then with regards to the urethral catheter, let's remove it. I'm not sure why it specifically is needed in her case. As we've discussed previously, the thing is we don't know if this patient is able to give us a history of whether she does have symptoms or not. I'm going to assume she can't give us that history. So essentially, a patient with yeast in the urine, whether symptomatic or asymptomatic. And then what I would do is obviously watch the patient clinically, and then repeat the urine MCNS later again. And if it consistently grows and you've sorted out the glycemic control, you sorted out the urinary catheter, then one could consider doing imaging to see if there's an underlying structural abnormality, fungus balls, etc. And if that is the case, well, then you've got to treat that accordingly. And then also, if the patient becomes unwell, then you can do blood cultures to look for any candidemia, and yeah, treat it accordingly again.
Okay, I think that sounds like a really reasonable approach. So many patients with candidemia have candiduria, but very few patients with candiduria have candidemia. And in medical patients, changing the catheter will clear the candiduria in a large proportion of patients. As Tari said, if patients are asymptomatic, they don't need treatment. And importantly, glucose control is also a major factor in this, as also antibiotic use. And so those things need to be addressed. As Tari suggested, if the candiduria persists, then image the urinary tract. and treatment is really only reserved for patients with evidence radiologically and I guess in terms of inflammatory markers of urinary tract infections, if they're symptomatic. A lot of people do amphotericin B bladder washouts. I know in the ICU, they love to do this. And there's just no evidence for this. And I just think that it's like probably quite an uncomfortable procedure. It could probably cause harm actually. And in my view, I think it should be discouraged. But interested in what other people think. So unless there are other comments on this case, maybe we can go to the next one. All right. So Tari, I guess this is for you also. A 7-year-old man with duodenal perforation and iatrogenic small bowel injury requiring resection is now on TPN. And you called because he has got a persistent fever on broad spectrum antibiotics. So will you start empiric antifungal therapy? What tests will you do? And what will be your choice of an empiric antifungal agent?
Sorry, Sean, so I assume that he's not specifically very unwell at this point in time, not in septic shock, etc.
No, he's not in shock.
Okay, well, I think we've got time in that case. So the thing is, you need to address, firstly, to start with the antibiotics. Why is the patient on antibiotics? Does the patient have any bacteremia or any other source of infection in the patient that requires the patient to be on broad spectrum antibiotics? And then I would take the approach of, is this a patient that is has a PUO, pyrexia of unknown origin, and then you essentially start from head to toe trying to find out if there's any sources, CNS, strokes, myocardial infarctions, DVTs, urinary infections, etc. But I mean, the problem is this guy's got a bowel injury, so I wouldn't start any antibiotics for now, especially seeing that he's fine. I would consider doing a CT abdomen first in his case, because we don't know if there's an underlying intra-abdominal infection. Is there any abscesses? So that would be abdominal issues, or has the patient got any GIT issues specifically? So, for example, does the patient have concomitant diarrhea, and then one would consider C. difficile as another problem, as another option over here. And choice of antifungal, well, for now I wouldn't. But if I do get called to say that he's got fungemia on a blood culture, then I would consider giving an echinocandin, whichever one we have, and as far as I know, we have micafungin, and then take it from there.
Thanks. Okay, yeah, I mean, so that was a really nice approach to this type of patient with fever in hospital on antibiotics. So as I described, the timing of empiric antifungal therapy depends on how sick the patient is and the risk of invasive candidiasis. So Tari, I mean, if the patient was in septic shock, you might be pushed to start echinocandin earlier. I've already spoken about the yield of blood cultures. Beta-glucan, a lot of people do, especially in private. The problem with it is that it's got a very poor positive predictive value, especially in the high-risk patients that you want to use it in. And so a positive test doesn't help you very much at all. And then the choice of empiric therapy depends on a number of factors, and I think we've discussed those. So any comments on this case? All right, then a final one for Tari. A 20-year-old man known with aplastic anemia who's awaiting a transplant. He's admitted with neutropenic fever. He's been neutropenic for a long time and has been on fluconazole prophylaxis for a number of weeks. Because of his presentation now with fever, he was started on broad spectrum antibiotics, and a blood culture was done from a central line which grows yeasts. Tari, what antifungal agent will you start? What else will you do? And tell us your thoughts on de-escalation and treatment duration.
Yeah, thanks, Sean. So we've got a yeast already growing on his central line. I would obviously want to also have a peripheral blood culture to also see if it's a fungemia, but I probably won't change my management at this point in time. But I would still like one. And then the problem is he's already been on fluconazole, and he's growing a yeast on fluconazole prophylaxis. So one would need to change antifungal. I would probably go again to an echinocandin in this case. In saying that, yeah, I mean, trying to think of the possibilities. I mean, Auris glabrata, which we know is not fluconazole, you might need to give higher doses. Cruzii, I don't think I would give voriconazole at this point in time. We're not too worried about a mold infection, but it is a possibility. But as we've mentioned many times, that the echinocandins are the preferred option. Okay, and then what else would I do? Okay, well, the central line, we need to discuss that. Does the patient really need the central line? Is it a tunneled line? Is it a precious line? But in saying that, even if it is a precious line, having a yeast on a central line blood culture is a big problem. And in most cases, that line, whether it's tunneled or non-tunneled, need to really strongly consider removing the line, and then need to go look in other areas. So as you mentioned before, ensuring that there's no endophthalmitis associated with that, and then clinically examine the patient to see that there's no metastatic spread of this yeast. And how long would I treat for? So after identifying the source, excluding eyes, and removing the central line, I would do a blood culture at 72 hours. If that remains negative, I would continue for 14 days for 14 days of an antifungal. If it does land up being sensitive to fluconazole, well, then you can go back to fluconazole, and that suggests obviously a source issue. And then the next question would be, is how long would the patient have his neutropenia for? And if after 14 days he's still neutropenic, well, and his absolute neutrophil count was less than 0.5, sorry, if it was more than 0.5, I wouldn't give him fluconazole prophylaxis. If it's less than 0.5, yes, I would put him back on his fluconazole prophylaxis. And then I've got to look at the antibiotics as well. Does he really need them after the 5 days have gone by?
Okay, thanks. Another comprehensive response. Yeah, I mean, we're expecting to be neutropenic because he's got aplastic anemia. And so I agree, I would start an echinocandin or amphotericin B if you don't have access, because he's had fluconazole exposure. His central line needs to come out. He doesn't have mucositis, he's not on chemotherapy. And almost in all cases, it should come out. In order to de-escalate, you need to speciate the yeast and then decide on continued therapy or prophylaxis, and you'll continue prophylaxis directed against this organism. And that might include an echinocandin or voriconazole. And then that needs to be continued until the neutropenia, as you say, is resolved. All right, so any comments on this case before I wrap up? And then I guess we can have a discussion. So one final slide is that infectious diseases consultation, just like for Staph aureus bacteremia, improves outcomes for invasive candidiasis, and like important outcomes like mortality. And infectious diseases consultations are also associated with longer durations of antifungal therapy. So perhaps this is a little bit different to antibiotic stewardship, where we strive for shorter if we can. But in fact, this just says that we need to treat these infections adequately. And so longer antifungal therapy is associated with better outcomes when ID is involved. It was also associated with more central line removal, more performance of echoes, which is interesting, and importantly, eye examination. You can imagine that if 2/3 of invasive candidiasis are associated with candidemia, Many of those are going to be associated with chororetinitis, and you can detect invasive candidiasis quicker on an eye examination than waiting for a blood culture. So I think these are important studies. So to sum up, invasive candidiasis is an important clinical problem. Non-albicans candidiasis is increasing, including in South Africa, as is resistance to antifungals in parallel with that. There are established principles of antifungal stewardship, which I've attempted to summarize and present to you. And we know that an antifungal stewardship program with ID and microbiology involvement can improve patient outcomes. And ignore the last point. So thanks very much. I'm interested in having a discussion.
Thanks very much indeed, Sean. That's fantastic. So Chad has his hand up. Over to you, Chad, first, and I'll ask my question afterwards. Thanks.
No, you can go ahead.
No, go ahead, please.
Okay, so just a few comments, because you had some questions about susceptibility for the various non-albicans candidas. So there are no breakpoints for Glabrata. So for fluconazole and voriconazole. So we sometimes can force the identification system to give us a MIC, but there's no real way to interpret it. And most of the time it's actually high, at least for fluconazole. Then for parapsilosis, actually we see quite a high rate of resistance to fluconazole. I don't know the exact numbers, but I think a lot of the time our parapsilosis is resistance. Then in terms of the Ampho-B bladder washouts, so this is something we advise for ICU patients. And I think, firstly, because, I mean, there's no evidence, I mean, as you say, I mean, not that there's no evidence, the evidence is limited, because there was a systematic review and meta-analysis that we consulted at the time that we decided to, routinely advise Ampho-B bladder washouts. And I think there was some supporting evidence for clearance. And the rationale for that as well is that you can't necessarily remove the catheter. You can remove the catheter, change the catheter, and that's usually our first port of call. But ICU patients often need their catheters, and we do the bladder washouts, and most of the time the candidiuria gets cleared. I mean, obviously that's not like scientific evidence, but anecdotally, we definitely do have good response to that, and that saves the patient getting a systemic antifungal. So I don't think we can discount it or completely. And then finally, for the endophthalmitis, I mean, it is something that we routinely advise, but I think it's quite difficult for us to justify and to well, I don't know how often it actually gets done. We don't really know when it should get done, who should do it. I think there's a lot of resistance to looking in the eye in general, and a lot of difficulty with that. So it would be nice to have maybe a clear guideline and on when and how and who and and then one more point, just regarding choice of empiric antifungal. Oftentimes when patients have not really had that much antibiotic exposure, they've had a maybe a primary laparotomy and then developed sepsis. Maybe there's a yeast on gram stain from an abdominal sample of fluid or a swab. We do often just start with fluconazole, and a lot of the times there wasn't really a necessity to go broader, but that's again anecdotal.
Okay, thanks so much. Sean, do you want to come back on that? Any of that?
No, thanks. Those are really great inputs. I mean, it sounds like it's very difficult to de-escalate for Glabrata, and in most cases, especially if patients are sick, it's probably prudent to continue with an echinocandin if that is isolated. I think we should have a look at this this meta-analysis of the bladder washouts again. I mean, clearance is not a very useful clinical endpoint, and if I remember correctly, it wasn't even that convincing. And you know, again, like there might be associated harm that isn't getting measured, and so I think we need to be very careful. But we should have this this discussion, and then yeah, patients in whom you culture or see on the gram stain yeasts from abdominal samples, I think are complex and difficult, and I think those require consultation. Maybe the reason why you've noticed that they improve on fluconazole is that they didn't actually need an antifungal in the first place. But yeah, I agree, those are difficult cases.
Thanks very much. So, I mean, firstly, fantastic talk. Thank you. Really, really, really useful. 2 questions. If you can just discuss the use of loading doses and at what point in your transplant patients is there any use for galactomannan? When you discussed about beta-glucan, you didn't discuss galactomannan. How would you use that biomarker, if at all? So loading doses for the echinocandins particularly, and whether you'd use in critical illness in antibiotics, we often increase doses. I mean, what are you thinking about fluconazole doses, and particularly in the echinocandins? Thanks.
Thanks. Yeah, so anidulafungin and caspofungin require loading doses. Microfungin doesn't. Guidelines recommend a loading dose of fluconazole actually for the first day, I think first day or 2 days, and then to go on to 400 daily as the standard dose. Needs to be adjusted in renal failure. Some people have said that even in mild renal failure, they don't adjust because actually you just achieve higher systemic concentrations and might be beneficial. Beyond that, I don't know about optimized antifungal dosing. I don't know how well that's been studied, and I think it's an important point and something we should I need to look at. Galactomannan, obviously that can go up as well in invasive candidiasis because it's in the candida cell wall as well. But I mean, really the time that we would use it if we're concerned about invasive aspergillosis. When in patients who we are concerned might have invasive mold infection, our approach is to do a high resolution CT scan coupled with bronchoscopy, and then we do galactomannan on the bowel fluid. We don't often do serum galactomannan. Sometimes we'll do it if the bronchoscopy is going to be delayed. And if it's elevated and the patient is at high risk, then that would help us to start voriconazole earlier. So that's generally our approach.
Okay, fantastic. Graham, I think you wanted to clarify something, principle 1.
Yeah, Sean, can I just ask the first point about fluconazole? Can you just repeat that? I just don't know whether I got that correctly, and then I'll follow the question.
About a loading dose?
No, your first principle of your 7 principles.
I think the first principle was about timing.
Okay, and then you said use fluconazole.
I don't remember. So in those studies, in those studies, and the one, let me just show you that slide again to remind myself as well. Yeah, so in the study on the left, they used fluconazole.
So that's what I didn't understand, because you say start fluconazole for any candidemia.
No, that was just, sorry, I'm just saying what they did in the study. That's not a recommendation.
Okay, yeah, because I was confused because later on you against starting fluconazole.
I apologize.
Yeah.
I apologize. No, this was an early study, and they used
okay, I get you. I was a bit, no, that makes sense. Yeah.
Okay.
So this was kind of old data where fluconazole was still an appropriate antifungal to start empiric therapy with. Yeah,
exactly.
I got you now. Thanks.
Okay, fantastic. Well, we're close to the top of the hour, but Eunice, yeah, please.
Hi, Sean. Thank you very much for an excellent presentation. So tell me, do you use Fungitel at all in your management of these patients for diagnosis or follow-up?
That's beta-D-glucan, right? So in hematology patients, we don't use it at all. We just don't find it useful. And in patients with intestinal failure and in ICU, we don't really get involved in ICU. That's just because of the setup and politics of a hospital. But in patients with intestinal failure, we occasionally use it. But again, I personally don't find it that helpful, because when it's positive, it doesn't help with treatment decisions. As I said, I think the value is in a patient who you are anyway going to decide to start an empiric antifungal, then I think it's useful to take it, and then to take it again when you're deciding to stop.
Thank you. One other question is that, is Candida ever a contaminant in the blood culture? Or do you always consider it a pathogen?
Guidelines always consider it a pathogen, and I think we do also.
All right, thank you.
Sean, is there, just with the beta-D-glucan, you're mentioning its use to stop. I mean, with PCT, you can either stop when it's within normal range, or if it's 80% of its, the peak value in an ICU. Is there any data on that for beta-D-glucan in that setting, or it's just yes or no?
As far as I'm aware, it hasn't been as well studied as PCT for reducing antifungals. I mean, I think it's a really nice study question. Also, the thresholds for starting and stopping for various fungal infections, including Candida, haven't been defined. And so that's also part of the difficulty. And I think this is an important question. Yeah. No, I think if it's negative, then you can stop.